We've had our brief overview of hematology, so now let's get into some specific hematologic disorders. First up is leukemia, which is a very big, broad term for a number of different types of cancers, where there is abnormal white blood cell counts, and usually manifests in the bone marrow, so just an excessive production of those leukemic cells, and they impair normal production of your red blood cells, white blood cells, platelets, so on. So leukemia is a big, broad term encompassing just a lot of different cancers. And what happens with leukemias, because it's so big and broad, you see just a cascade of effects, and patients may have one or multiple these signs, symptoms, may affect the liver or the joints or lymph nodes. It just depends on that patient and that specific type of leukemia. Then we've got polycythemia, which is an increase in your red blood cell mass within the blood, and can result from dehydration. So we're looking at that ratio again, or could be genetic. Signs and symptoms are very broad, generic. Look at fatigue, dizziness, headache, maybe some blurred vision, but looking at things like bruising and petechiae, enlarged spleen, enlarged liver, might be signs of polycythemia. Then disseminated intravascular coagulopathy, or DIC, very interesting disorder in which you've got abnormal clotting after trauma. Sometimes in pregnancy, certain diseases can cause it, but very common, commonly due to trauma, in which there's both bleeding and clotting occurring, excessive bleeding and clotting occurring. We've got these microclots. We've got too much clotting, but they're producing microclots and getting caught in very small vasculature. And then because of the microclotting, all of your clotting factors are being used up, taken up, and so there is also too little clotting. So if you're bleeding out somewhere in which large clots are needed to stop that bleeding, your body is not able to form those large clots, so you actually have too much clotting and too little clotting at the same time. So we've got clotting and bleeding at the same time, and those microclots end up in the small vasculature, leading to organ ischemia, organ failures, and then your patient is also at risk for major hemorrhage and hemorrhagic shocks. Next up for blood disorders, bleeding disorders, is hemophilia, just a condition with uncontrolled bleeding, loss of bleeding controls and those control mechanisms. There are a few different disorders. They are inherited, they are genetic. The patient is usually being treated with concentrated clotting factors, but it depends on the type of hemophilia. There's A, B, and C. We won't get into the nuts and bolts of differentiating it, but just know their clotting is impaired and at high risk for hemorrhage. And if you have a low platelet count, you have thrombocytopenia. And with this, bleeding can occur at any time. You might see blood in stool, in the urine, easily bruised. So low platelet counts can't clot quite as well, and causes easy bleeding. Lastly, for bleeding disorders, let's take a kind of a deeper dive into sickle cell disease, another genetic inherited blood disorder. It affects the red blood cells. This hemoglobin S, that sickle cell, either has this limited oxygen carrying capacity, and in low oxygen states, it will actually crystallize. So it is unable to flow through your blood cells. It gets stuck very easily, and it can block flow when it gets stuck to your organs, to your tissues, can cause ischemias. When it comes to a sickle cell emergency, it can also be called vaso-occlusive crisis. Patients might have acute chest syndrome or splenic sequestration syndromes, and significant anemia. So those sickle cells, are they getting caught? Where are they getting caught? So vaso-occlusive crises, they're being caught throughout the body. Acute chest syndrome, you can actually see sickle cell patients have MIs because these blood cells are being blocked up in the coronary arteries. Splenic sequestration, we've got those sickle cells being caught in the spleen, enlarging the spleen. You'll actually be able to palpate that enlarged spleen. So these sickle cell emergencies are true emergencies. They can be very painful for the patient. So pay attention to the patient's history and exactly which symptoms they're exhibiting, and whether or not they've had them in the past with past flare-ups. On your assessment of your sickle cell patient, we're going to be asking some very pointed questions. What their pain is like, what the severity, is it similar to prior flare-ups, prior episodes? What does it feel like? Is it any different? Any medications that has helped them in the past? Any special medications that are on right now? So we're going to be pretty aggressive with our pain management. So just asking them what has worked and what hasn't worked in the past will help us a lot. And then any previous complications. So the symptoms they're experiencing, have they experienced them in the past? Are they new? Is the pain even more severe than it has been in the past? So if they've got new symptoms, differing levels of pain, it might be this crisis is definitely different than other crises or past crises, and we need to consider just all the other different underlying causes. On assessment, our vital signs of concern for our sickle cell patient: increased temperature may lead us to believe or push us down a path that they may be going into sepsis or septic shock. On top of that, hypotension, tachycardia, tachypnea, and looking for hypoxia, and then any altered mental status is concerning. And with these patients, severe headaches or other neurologic signs are concerning. As paramedics, what are we going to do for your sickle cell patient? Give them oxygen if needed for hypoxia. And it helps reduce the cell clumping in those sickle cells. So remember, in low oxygen states, those cells can crystallize. We want to avoid that, so giving supplemental oxygen helps. Giving fluid if they are dehydrated or show signs of dehydration, and then a fairly aggressive pain management and to keep them comfortable. This sickle cell crises can be very painful, so we are going to administer the appropriate pain management. Now let's get into some pharmacology and medications that we might be giving, or you might be seeing patients prescribed, or medications in the hospital themselves for these varying bleeding disorders, conditions, or just medications that affect the hematologic system. Let's start with anticoagulants, big, broad term. So anticoagulants make you coagulate less, make you clot less. It's usually prophylactic therapy. We don't want clots to form just to begin with, so we're inhibiting clot formation. If you already have a clot in your body, we are preventing that clot from extending, from getting bigger. So anticoagulants, we just don't want you to clot quite as much. Lots and lots of anticoagulants out there. They all work a little bit differently, all going after slightly different clotting factors in different ways. but the effect at the end of the day is the same. Anticoagulation. We'll pick out a few here and highlight them. But there are tons of anticoagulants out there. But at the end of the day, they're all anticoagulants. First we'll talk about is warfarin or Coumadin. And warfarin works by blocking vitamin K. Not K as in potassium, but vitamin K, especially in the liver. And with that, by blocking vitamin K, we are blocking the production of all these clotting factors there. Now, Coumadin, typically given as prophylaxis, especially for patients who have had DVTs, who have had PE, patients who have AFib might be on Coumadin or another anticoagulant for clotting prophylaxis. Warfarin has a lot of side effects, including, not surprisingly, hemorrhage. So if we're making you clot less, you're going to be more susceptible to bleeding. But rashes, easily bruises that show up very easily. Warfarin does cross the placental barrier, so this is a Category X medication for our pregnant patients. And then our dosing needs to be calibrated per patient. So every patient's going to get kind of slightly different dose of warfarin depending on their needs. This is based off a prothrombin time, a PT. It's a blood test, it's a clotting test, and so we want to give enough warfarin for them to slow their clotting down a little bit, but not too much, so that it is runaway anticoagulation. So it does require frequent lab testing in the early stages until the physician can kind of zero in what the patient's dose should be. Because warfarin blocks vitamin K, it's got an easy antidote. We just give vitamin K. We can also give FFP or concentrated factor 9, but the go-to in the hospital is going to start them on vitamin K if they're clotting too much, if there's an overdose of warfarin. There are other oral anticoagulants that are newer generation than warfarin. These require less lab monitoring, if at all. So drugs like Eliquis, Xarelto, Pradaxa are the newer generation anticoagulants. Put on a set dose. They're more stable. They're more predictable than is warfarin, so that lab monitoring is not needed. So we're seeing Eliquis, Xarelto, Pradaxa much more commonly prescribed than we do warfarin nowadays. Continuing with our anticoagulant, let's talk heparin. Heparin is actually naturally formed in our lungs, our livers, so it is an endogenous substance. Heparin, I want to point out that it does not have fibrinolytic activity. Heparin is not a clot buster. It is an anticoagulant. It will slow down the clotting process, but it does not break apart existing clots. There are actually a couple different types of heparin. One is unfractionated heparin, and so it goes in, inactivates a number of clotting factors, and prevents clot stabilization, so your body can't finish the clot formation process. That unfractionated heparin is just called heparin. So if you pick up a bag, it says heparin on it, you know you've got that unfractionated heparin. We also now have low molecular weight heparin, which only contains that anticoagulant portion. The other parts of it in the lab have been removed, like saccharides, the parts that we don't really need in that medication. We just need the anticoagulant part. So that's your low molecular weight heparin, kind of newer generation. But again, if you go into the hospital, go into your truck, maybe you carry it, your service carries it, you pick up a bag, it says heparin on it, that is unfractionated heparin. So there we go. That bag says heparin, so it must be heparin. And that unfractionated heparin. Again, we're using this for clot prophylaxis. For surgeries, the MIs, especially non-STEMIs, giving them heparin before there's going to be a significant time lag between diagnosis and getting into the cath lab. Other prophylaxis with DVTs and PEs. Heparin does not cross the placental barrier like warfarin does, so it is safe for pregnant patients. The dosing for heparin is weight-based, so it's going to be a little different for everybody. There's going to be an initial bolus, and then we'll hang a drip. So that bolus is usually 50 units per kg, and then the drip will start it at 15 to 25 units per kg per hour. And then that dose will be adjusted up or down using another clotting lab test as PT-INR. So warfarin, lab test we're looking at as a PT, and then the PT-INR we're looking at for our heparin dosing, whether or not we're going to increase or decrease our dose. Then we get into our low molecular weight heparin, and again, our low molecular weight heparins have taken out kind of the parts of the heparin that we don't really need for treatment for anticoagulation. We've only kept the anticoagulant parts in there, and those deactivations of the clotting factors in there. So some advantages here. There's a lot less monitoring required, lab monitoring required. We can also administer our low molecular weight heparins sub-Q, so you can prescribe this to a patient and they can administer it to themselves at home in a sub-Q fashion. Most popular one by far that you'll see is Lovenox. So if you see Lovenox, that is a low molecular weight heparin. So again, if you see a bag that says heparin on it, that's your unfractionated heparin. If you see Lovenox or Fragmin, those are your low molecular weight heparins. Newer generation with the kind of the unnecessary parts taken out. Just like warfarin has an antidote, heparin has an antidote as well. It's protamine. Protamine goes in and inactivates any unbound heparin. So the heparin's already bound, started doing its thing. Can't do anything there, but protamine will go in and scoop up any of the unbound heparin and deactivate it. Next up, under anticoagulants, we have antiplatelet drugs, wherein we're going after, platelets, right? So we are inhibiting platelet aggregation, and we're making platelets kind of slippery. So we're using this mostly prophylactically, especially with aspirin. So aspirin, categorized broadly as an NSAID. Our typical dosing, 81 to 324 milligrams. A patient might be taking that, it's just that baby aspirin every day, so taking 81 milligrams every day. If we have a chest pain patient, let's say for example, we might give them a full 324 dose of aspirin as that anticoagulant, as that antiplatelet drug. So if they already have a clot in there formed, we're not making the clot bigger, we're making those platelets slippery, and so we don't have new clots forming, and existing clots are not getting larger. And how does aspirin work? Well, it irreversibly inhibits cyclooxygenase and prevents thromboxane A2 formation, and blah, blah, blah. This means that the inhibition of that platelet is for the life of that platelet. So we get slippery platelets, and then it's for the life of that platelet. So we don't get normal platelets, again, until new platelets are formed. So the life of a platelet, somewhere between a week and 2 weeks, give or take. So as new platelets are formed, they are acting normally, but when aspirin is given, it does affect that platelet for the life of the platelet. A couple other antiplatelet drugs that we have. One is Plavix, blocking ADP receptors. Plavix is pretty common. Some agencies carry it as an adjunct to aspirin or given instead of aspirin. Another one is Integralin, inhibits glycoprotein 2B3A, and given IV and usually given during invasive procedures. So Integralin, you usually see in the hospital or interfacility transports, given IV. Plavix, you might see at home, your patient taking it at home, or it might be on your truck and given instead of aspirin. Alright, now let's go even further. We've done the anticoagulation and antiplatelets. Let's go straight into the heavy hitters and our thrombolytics. Our thrombolytics, or fibrinolytics, are clot busters. So they go in, they find a clot, and they break up that clot. So they completely destroy the clot, and that's their job, to go in, break up the clot, restore blood flow. And how are they doing this? Well, they're dissolving the clot by converting plasminogen to plasmin, and plasmin digests clots. So as part of the clotting process, not only does your body produce clots, but at some point it's done its job and needs to break apart the clot. And so your body naturally does that. We're just helping this process along and speeding up the process a little bit. So that plasmin digests clots, and that's how our thrombolytics, fibrinolytics, break up our clots. Some common ones, some common TPAs. All your places. So your atoplase or activase. You've got TNcase, retivase. All those are out there and readily available. If you have a protocol in your agency to use a thrombolytic, you will have a pretty extensive check sheet to go through before you administer this medication, because we want to make sure that we are administering any thrombolytic safely and effectively. So we're going through, this is the AHA's check sheet, and if you can get all the way down and you're not running into any contraindications for giving it, we go ahead and give that thrombolytic. So we're reducing risk and improving effectiveness. On the other side of the coin, let's talk about TXA. Instead of breaking clots apart, let's form some. So TXA is an anti-fibrinolytic and actually inhibits plasmin formation. So remember that our thrombolytics, our fibrinolytics increase plasmin formation. This one inhibits it. So it slows the breakdown of clots. It's allowing your body to form clots and then keep those clots longer. So it's inhibiting the breakdown of clots. TXA has been around for a long time, and if you've got any skincare products, especially like facial skincare products, you probably have some TXA in there. Standard TXA dose, 1 gram IV over 10 minutes, and common indications for it, major traumas, down to postpartum hemorrhages, hemorrhagic shocks, and even nosebleeds with topical TXA. Lastly, let's talk about blood transfusions and blood administration. For blood transfusions, blood administration, we would love to have a type and cross match. So our types are your letters, your A, B, and O groups. And then your cross-matching is the RH factor, you're positive or you're negative. So see our universal donor here at O negative and our universal recipient at AB positive. So if you are carrying pre-hospital blood for administration in the field, you're most likely carrying O negative blood, but you're working with a blood bank. You've got a program in place. So in the hospital, we're going to type and cross match out in the field. We can't do that quickly and easily, so we go for a universal donor type. When administering blood, really one of your major jobs is to look out for transfusion reactions. These can be hemolytic reactions, they can be allergic reactions, they can be febrile reactions. So depending on how the body reacts and responds to the transfusion, whether it's allergic, whether they spike a fever, so we are looking out for these signs and symptoms of these transfusion reactions. So right, we might cause a circulatory overload, causing issues with cardiac function, and so we're giving too much volume, right? There are lung injuries, acute lung injuries we need to look out for. Again, so we're monitoring vital signs, we're monitoring signs and symptoms as we administer this blood, and if we If we see anything popping up, the first thing we're going to do is end that transfusion, flush the lines, and then treat signs and symptoms that have presented to us. If you have any questions, feel free to let us know.